There's a pill that might be sitting in your medicine cabinet right now, maybe on your nightstand, maybe in your purse, maybe in that drawer in the kitchen where you keep the things you reach for without thinking, the things you've been taking for years because they work, because they're familiar, because nobody ever told you there was anything wrong with them. And that pill, that specific, enormously common pill that millions of older adults take every single day, is quietly putting their hearts at risk in a way that almost nobody is talking about. Not in waiting rooms, not during 15-minute appointments, not on the packaging, not in the commercials. I'm going to talk about it today, because I've spent years watching what happens when this information arrives too late, and I am done staying quiet about it. My name is Dr. Gene Walker, and what you're about to discover in the next few minutes has two levels. The first one will surprise you. The second, the one I'll reveal toward the end, is the one nobody sees coming. The one that explains why this risk is so invisible until it suddenly isn't. Wait, because before I tell you which pill it is, I need you to understand something about the aging heart that almost nobody knows. Something that completely changes the weight of everything I'm about to say. If you leave this video without understanding this part, you'll miss the most important piece. Subscribe to the channel and leave a like right now. And tell me in the comments, how many medications do you take every day? I want to read your answer. Stay until the end. Because in the last few minutes, I'm going to give you something concrete. 5 specific steps you can take starting tomorrow morning. Let me ask you something uncomfortable. When did you last think about your heart? Not as something to worry about, but as something to actively protect. Not after a scare, not after a diagnosis, just proactively, deliberately, on a regular Tuesday morning, thought about what you were doing for it and what you might be doing against it without realizing. If you have to think about it too long, that answer is already important information, because there's a category of risk for the aging heart that almost nobody addresses with the precision it deserves. Not the obvious risks, smoking, obesity, physical inactivity. Those get talked about. Those are on the posters in the doctor's office. Those are in every health article you've ever read. I'm talking about something hiding in plain sight. Something so normalized, so embedded in daily routine, so casually recommended that its danger has become invisible. Something that millions of older adults consume regularly, convinced it's harmless, while it quietly works against the very organ they most need to protect. Pay attention to this next part, because what I'm about to tell you is the foundation of everything else. The aging heart is not simply an older heart. It's a biologically different heart, with different response mechanisms, with specific vulnerabilities that the young heart doesn't have. And what is relatively safe for a 30-year-old heart can be actively dangerous for a 70-year-old heart. Not because the substance has changed, but because the system receiving it has changed profoundly. Let me explain exactly what happens to the heart as it ages. Not in vague terms, with precision. Because that precision is essential for understanding why certain medications become so dangerous with age. The first change is the reduction of cardiac reserve. A young heart has an extraordinary capacity for adaptation. It can increase heart rate, contractile force, and cardiac output in response to any physical or pharmacological stress. The aging heart has lost a significant portion of that flexibility. It responds more slowly. It adapts less efficiently. And when something, a medication, a stress, a sudden pressure change, exceeds that reduced reserve, the consequences are far more serious than they would have been 20 years earlier. The second change is myocardial stiffening. The muscle fibers of the heart become progressively less elastic with age. The filling of the left ventricle, the diastolic phase of the cardiac cycle, becomes less efficient. This creates a specific vulnerability. The aging heart depends much more heavily on heart rate to maintain adequate output. When something lowers the heart rate or blood pressure too much, the aging heart cannot compensate with the same speed and effectiveness as a young heart. The third change involves the electrical conduction system. The cells of the sinoatrial node, the natural pacemaker that generates the cardiac rhythm, decrease progressively with age. The conduction system becomes more vulnerable to arrhythmias, more sensitive to drugs that influence it, less capable of returning quickly to normal after a disruption. These three changes together create a heart that still functions, often very well, but that has lost the safety margins that protected the young heart. A heart working with reduced reserves, with less capacity to manage the unexpected. That pays a much higher price for any disruption the young heart handled without difficulty. And now I'll tell you which medication exploits exactly these vulnerabilities. But first, there's something even more important you need to understand. Something that explains why this problem is so hard to see until it's too late. There's a phenomenon cardiologists call the threshold effect. The body has extraordinary compensation systems. It can adapt to progressive dysfunction for years, decades, without producing obvious symptoms. The heart works harder to compensate for a valve that's functioning less well. Blood vessels adapt to pressure that rises gradually. The conduction system finds alternative pathways when the main ones deteriorate. This is remarkable, while it lasts. But it has a hidden cost. When the compensation system is at maximum capacity, when it has already used all its resources to maintain function under normal conditions, any additional disruption can exceed the compensation threshold and produce an acute event that appears to come out of nowhere. A medication that would only cause a slight drop in blood pressure in a young heart with ample reserve produces a serious hypotensive episode in an aging heart that has already used all its compensatory reserves just to maintain adequate pressure. A medication that would mildly slow the heart rhythm in a young heart produces symptomatic bradycardia in an aging heart with an already compromised conduction system. A medication that would have negligible effects on electrolyte balance in a young heart produces a critical potassium alteration in an aging heart with kidneys functioning at 60% of their original capacity. The medication hasn't become more dangerous. The system receiving it has less margin for error. And that reduced margin transforms a theoretical risk into a real one. Wait, because now comes the part that nobody tells you clearly. What am I talking about? Non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, naproxen, diclofenac, ketoprofen, indomethacin, the common over-the-counter pain relievers that millions of older adults take regularly for joint pain, arthritis, back pain, muscle aches. Medications you can buy without a prescription, that you take without thinking, that feel safe because they're familiar, because they're accessible, because you feel better after taking them. And here is the paradox that concerns me most. These drugs work. They reduce pain, they reduce inflammation, they improve quality of life in the short term. And it's exactly that effectiveness that makes them so dangerous. Because people take them, feel better, reach for them again next time, build a habit, without ever knowing what they're costing their heart, their kidneys, their blood pressure. Let me explain the mechanisms one by one, with the precision they deserve. The first mechanism is sodium and water retention. NSAIDs inhibit the production of renal prostaglandins, molecules the kidneys use to regulate sodium elimination. When these prostaglandins are blocked, the kidneys retain sodium, and sodium retains water. Blood volume increases, blood pressure rises. In a young person with healthy heart and kidneys, this effect is modest and temporary. In an older adult with existing hypertension who is already taking antihypertensive medications to control it, this effect can completely cancel out the efficacy of those blood pressure medications. Pressure rises despite the therapy. The heart works against greater resistance. And nobody connects the pressure increase to the fact that the person started taking ibuprofen for their knee. The second mechanism is reduced renal blood flow. Prostaglandins don't just regulate sodium elimination, they also regulate blood flow through the kidneys. In normal conditions, in young people, this isn't a problem. But in older adults, especially those with heart failure, reduced kidney function, low blood pressure, or dehydration, the reduction in renal blood flow caused by NSAIDs can precipitate acute kidney injury. And when the kidneys aren't working well, potassium rises. And elevated potassium, hyperkalemia, is one of the most dangerous causes of serious cardiac arrhythmias, including ventricular fibrillation, including cardiac arrest. The third mechanism, and this is the one that concerns cardiologists most, is the direct effect on the myocardium and conduction system. NSAIDs inhibit cyclooxygenase, the enzyme that produces not only the inflammatory prostaglandins that cause pain, but also prostacyclin. Prostacyclin is a powerful vasodilator and platelet aggregation inhibitor. Its reduction, produced by chronic NSAID use, shifts the balance toward vasoconstriction and toward a greater tendency to form blood clots. In practical terms, regular NSAID use increases the risk of coronary thrombosis, increases the risk of myocardial infarction, increases the risk of ischemic stroke. These risks are documented, quantified, present in the technical data sheets of these medications, but rarely communicated clearly to the people who take them regularly. For older adults with atherosclerosis, with arteries already partially obstructed, this shift in balance may be sufficient to precipitate an acute event that the cardiovascular system, with its reduced reserves, cannot manage. There's a fourth mechanism I want to show you, because it explains why the problem is even more serious than it appears. NSAIDs interact dangerously with almost all the medications that older adults commonly take. They interact with anticoagulants, warfarin, dabigatran, rivaroxaban, increasing bleeding risk. They interact with diuretics, reducing their effectiveness and risking cardiac decompensation. They interact with ACE inhibitors and ARBs, the blood pressure medications most commonly prescribed to older adults, reducing their effectiveness and increasing the risk of acute kidney injury. They interact with beta blockers, reducing their antihypertensive effect and increasing the risk of heart failure. This is not a theoretical list of pharmacological interactions from a textbook. This is the daily reality of millions of older adults taking 3, 4, 5 medications for their chronic conditions, and then adding an NSAID for pain without telling their doctor, without thinking it could change anything, convinced that an over-the-counter pain reliever doesn't count as a real medication. It counts. It absolutely counts. Now comes the part I promised to reveal toward the end, the one nobody expects, the one that completely changes the perspective. The problem is not that NSAIDs are bad medications. The problem is that they were designed and dosed for young organisms, and they are being given to aging organisms that metabolize them differently, that have less efficient kidneys, that have hearts with less reserve, that are already taking other medications with which they interact. The half-life of NSAIDs, the time the body takes to eliminate half the dose, lengthens significantly with age. A drug that a 30-year-old eliminates in 6 hours, a 70-year-old with reduced kidney function may take 12 or 16 hours to eliminate. This means blood concentrations of the medication are higher and last longer. The effect is amplified. The risk is multiplied. And there's something even more specific. NSAIDs reduce levels of prostaglandin E2 in the myocardium. This prostaglandin has a direct protective role in cardiac cells. It regulates contractility, protects against arrhythmias, modulates the response to ischemic stress. Its chronic reduction, produced by regular NSAID use, removes a biological protection that the aging heart cannot afford to lose. This is not a hypothetical risk. It is a precise biological mechanism, documented, quantified, and rarely explained with this clarity. So what do you do? What do you take when the pain is real, when the arthritis is debilitating, when the back pain won't let you sleep? The first step is to review with your doctor every NSAID you're currently taking, including occasional ones, including over-the-counter ones, not necessarily to eliminate them, but to evaluate whether there's a safer alternative for your specific cardiovascular profile. Acetaminophen, paracetamol, is generally much safer for the heart than NSAIDs. It has other risk profiles, hepatic if used in excessive doses or with alcohol, but it doesn't cause sodium retention, doesn't reduce renal blood flow, doesn't alter the balance between prostacyclin and thromboxane. For many types of chronic pain in older adults, it's the safest available alternative. The second step is to explore non-pharmacological alternatives for chronic pain. Physical therapy, adapted movement, thermotherapy, TENS units, local injections for arthritis. There are many tools for managing chronic pain that don't carry the systemic cardiovascular risks of oral NSAIDs. Not for everyone, and not in every case, but for many older adults, a combination of non-pharmacological approaches can significantly reduce reliance on systemic pain relievers. The third step, if NSAIDs are truly necessary, is to use them at the lowest effective dose for the shortest possible time, always with food to reduce gastric risk, and always under medical supervision that monitors blood pressure, kidney function, and cardiac parameters. The fourth step is to always tell your doctor about every medication you're taking, including over-the-counter ones, including supplements, including medications you take occasionally. Pharmacological interactions are not predictable if the doctor doesn't know what you're taking. That complete and honest communication is the most effective defense you have against the risks of polypharmacy. The fifth step is to measure your blood pressure before and after starting an NSAID, even for a short course. If your pressure rises, if ankle swelling appears, if you notice increased shortness of breath, these are signals that the medication is producing cardiovascular effects that cannot be ignored. I want to tell you something before I close. I have spent years in operating rooms and cardiac units. I have seen hearts that could have lasted much longer if someone had said the right things to the right people at the right moment. Not complex diagnoses, not sophisticated interventions, information. Simple, precise, accessible information. The aging heart is not a weak heart. It is a heart that has worked for decades with extraordinary faithfulness, and that deserves to be protected with the same care and intelligence with which it has worked for you. That protection doesn't require great resources. It requires awareness. It requires knowing which medications you're taking and what they're actually doing to your body. It requires having honest conversations with your doctor. It requires not assuming something is safe simply because it's common, simply because it's sold without a prescription, simply because everyone takes it. You now have that awareness. You have the information you need to protect your heart intelligently. Not next month, not when the symptoms become impossible to ignore, starting tomorrow morning. If this video gave you something concrete and useful, I'm asking you for one thing only. Share it. With your mother, your father, an older friend who takes pain relievers every day without knowing what they're doing to their heart. With anyone you love enough to send this information before they urgently need it, not after. One click from you can make the difference between receiving this information in time and receiving it too late. Subscribe to the channel and turn on notifications. Every week I'm here with practical, science-verified information, explained without alarmism and without hidden agendas. Because I believe heart health shouldn't be a privilege for those lucky enough to have the right information at the right moment. It should be accessible to everyone. And tell me in the comments, are you currently taking any pain relievers regularly? How many medications do you take every day? What surprised you most about what you heard today? I read every single comment because what we're building here isn't just a channel. It's a community of people who take their own health seriously and the health of the people they love. I'm Dr. Gene Walker. Thank you for the time you dedicated to something this important. Your heart has worked for you every single day of your life, without ever stopping, without ever asking for anything in return. It's time to work for it too, with the same intelligence, the same consistency, the same care. See you soon.